Hi, everybody. We're here for genetic and genomic testing. This is a very important unit of content for you to understand, but most of it will sound kind of familiar to you. And it's really not hard content. So, we'll get started with our objectives. By the end of this unit, you should be able to compare the different types of genetic testing. That's going to take a little while. And then we'll look at some of the problems with genetic testing, how differences in populations might affect the validity of genetic testing, especially carrier testing. We'll discuss the implications of direct to consumer genetic testing. Companies like 23andMe, MyHeritage, Ancestry all have services for that. We'll discuss the risks and benefits of genetic testing for people and identify some dependable online resources. That's really one slide with a couple of links. So we'll go ahead and get started. What is genetic testing? Well, according to your book, genetic testing is the analysis of DNA, RNA, chromosomes, proteins, and sometimes protein metabolites to identify heritable variations in genes and or chromosomes. We can use it for a number of things. In the past, this testing was really expensive and really only done if you had a clear-cut clinical indication or for research. But as the study of genomics evolves, with the completion of the Human Genome Project and a lot of discoveries in the remaining 19 years, technology's become a lot more accessible and affordable. And that's paved the way for things like direct-to-consumer testing, which, just like it sounds, markets directly to consumers. Most of them are driven by curiosity. It's really a recreational use of genetic testing. They want to know where their ancestors came from, who they're related to, and they might be interested in certain health information, although this isn't really the best source for it. There are some pros and cons to DTC marketing. We'll discuss them a little later in this presentation. For now, we're just going to stay focused on medical applications, the types of tests, how samples are collected, and who benefits from genetic and genomic testing options for medical use. Okay, so this is how some of the samples can be collected. And you see this little infographic here. If you've watched crime TV shows, you know that DNA could really be collected from just about any biological material, a hair, a drop of blood, a little bit of saliva on a glass. They'll sweep the scene for any biological material, urine, semen, feces, you name it, anything, skin cells. They all have a nucleus, and those nuclei all have chromosomes in them. But the more common way we do it in medicine, generally speaking, you're looking at like that second slide on the top from the left, the buccal swab. You take a long-handled cotton swab and you scrape a few epithelial cells out. It doesn't hurt. It's not invasive. There's no risk to the client. We still get the genetic material we need, so that can be analyzed. Second would be a blood draw. And we'll talk about cell-free DNA a little later in this presentation and why a blood draw might be preferable. A saliva sample. Newborn heel prick, although normally what we do analyze in the newborn screen are the proteins, the abnormal proteins. When a gene is faulty, genes code for proteins. It'll code for the wrong protein or a protein that is not beneficial to the body. So we're looking for that, or we're looking for a buildup of protein metabolites, meaning that protein was manufactured and now it's breaking down. We can collect it from amniotic fluid. If we're trying to get it from a fetus, we can collect it from chorionic villus sampling, which involves going directly, put a little tiny device through the cervix into the uterus, and you sample a very, very small amount of cells guided by ultrasound from the fetal side of the placenta, where those chorionic villi, those finger-like projections, have some of that fetal genetic material. Fine needle aspiration, here they're using it for bone marrow, but you can also do any kind of tissue biopsy and analyze the material you find to get your genetic material. Okay, now this is a pretty lengthy slide. It's got a lot of stuff crowded on it, but these are all the different types of tests we do for genetics, at least for medical applications. Primary use for genetic testing is diagnostic testing at this moment in time. Predictive testing might catch on a little bit more as insurance companies start to cover it and as the benefits become more clear to people, including providers. So we have diagnostic testing used to all be done with the karyotype. That was the most sophisticated tool we had, and that really tested. It's a snapshot of chromosomes taken from a cell that is in the metaphase of mitosis. And then we arrange the chromosomes from the upper left, going across. Start with the biggest. Chromosome number 1 is the largest, has the most genetic material, until we get to the last autosome, which is chromosome number 22, pair number 22, has the smallest amount of genetic material. And then that's followed by the sex cells. And that gives us a pretty good idea. Do we have 46? Do we have a euploid number of chromosomes in a human cell, or do we have an aneuploid? Do we have an extra chromosome? Do we have a missing chromosome? Maybe we can see if the chromosome is missing part of an arm. Sometimes we can see things like translocations, which is a different topic for a different day. But that's one way that we can test. Obviously, if we see 21, the 21st pair of chromosomes having 3, that's diagnostic for Down syndrome. So we can diagnose Down syndrome through the karyotype. And then we have molecular genetic testing. And this looks a lot of times at single nucleotide pairs or very short strands of DNA material. And it looks at the sequence of bases. It looks at like that guanine, thymine, adenine, thymine, right? And we look for predictable patterns. Now, since the Human Genome Project, scientists have been able to take healthy populations and compare them to people who have known genetic disorders. And they look for where exactly that gene is different in those two populations. And that's how they've isolated the gene locations or the gene locus for a lot of different heritable disorders. So we can look at things like deletions, insertions, micro deletions, and we can see what might be going on there. We can also look at variants of base pairs, to look for like cystic fibrosis, for example. We know that there are certain combinations of bases that code for that CTFR variant that causes cystic fibrosis. We can look at changes in proteins. For example, we can do diagnostic testing to diagnose sickle cell anemia. And what we're really looking for is the different types of hemoglobin. And they'll classify how much hemoglobin A, how much hemoglobin S, how much hemoglobin F, and a high amount of hemoglobin S means that you had a gene that coded for the sickle-shaped hemoglobin protein. So that's another way we can diagnose using genetic testing. We can look for changes to cells. For example, if you take a biopsy of a tumor, you can see the genetic changes within the cell. All cancer is genetic, it's just not all heritable. So you would see the disorganization of chromosome material, you would see extra chromosomes. We'll talk more about cancer in that unit. You can also sometimes look for epigenomic changes. There's a really good documentary about epigenetics. I think it's The Ghost in Our Genes. And it talks about how, identical twins start out very identical. And then as they're exposed to different environmental things, there are epigenomic changes that can be tested for to see if a gene is turned on or off. We have predictive testing. This is probably going to be much more useful in the future when we have more information. There is pre-symptomatic testing. For example, we have Huntington disease. It's a dominant disorder, so people always express the phenotype if they live long enough. But it doesn't manifest until the patient is somewhere in midlife. After 30, definitely, usually in the 40s or 50s. So that would be one type of pre-symptomatic disorder. And then we have predispositional testing. And this tells us about a patient's risk. You've heard of BRCA. Not everybody with the BRCA1 variant gets breast cancer or ovarian cancer, but they're much more likely than the general population. And so we would use that information to screen them more frequently and with more accurate diagnostic methods. Another example, there's a disorder you're going to learn about, alpha antitrypsin deficiency, AATD. It predisposes people, that word predispositional, to chronic obstructive pulmonary disease, or COPD. If a person knows that they are at risk for that disorder, they can be counseled to avoid all forms of tobacco smoke or other respiratory irritants that might um, alter the structures of the respiratory tract. They might be encouraged to get flu vaccines, pneumonia vaccines, all to prevent damage to the lungs and maybe delay or prevent the onset of COPD. So that's predictive testing. Carrier testing is done, generally speaking, now this is changing, but right now, usually it's reserved for people who have a history of something that is genetic. Maybe there's a history of sickle cell disease or cystic fibrosis, and they want to know, do they carry a recessive copy of that gene? And does their partner carry a recessive copy of that gene? How might that affect their decision to start a family or the way they start a family? Certain ethnic groups are also offered carrier testing. Again, I'm going to mention people of Ashkenazi Jewish ancestry. That population had very little diversity for a lot of years. There was a lot of intermarriage because there was so much discrimination. They never married outside of their ethnic group. And so you see certain disorders repeated, things like Tay-Sachs or Fanconi's anemia or thalassemia. So those folks are usually ordered carrier or offered carrier testing. Now, with the greater availability, I am seeing some doctors recommend it to all expectant parents, and they come in all freaked out because it turns out most of us are carriers of something. But that something is rare. So the chances that we're going to marry somebody or mate with somebody who has that same recessive gene are smaller. And we can test the partner and make sure that they know, you're at risk or not at risk. That's carrier testing. Prenatal testing, I did mention how we can do amniotic fluid or chorionic villus sampling. We can also do pre-implantation genetic testing where you sample a cell from an embryo that has been fertilized outside of the human body. And you implant the ones that do not have any trisomies or other genetic disorders. And if there's a known genetic disorder in the family, say neurofibromatosis or cystic fibrosis, anything that person, they can test that cell for that disorder and decide to discard that embryo and not implant it. Less invasive is always preferred. Cell-free DNA, I'm going to talk about that on the next slide. It's not considered to be as accurate as amniocentesis, but it is certainly less invasive and carries little risk to the pregnancy. And last but not least, we have newborn screening. That is going to be a topic for another module on pediatric disorders. But newborn screening is really good at catching things that are rare, that are difficult to detect on physical exam by the pediatrician, and that can cause severe harm, but something that's treatable. So there are all these conditions for inclusion of disorders onto the newborn screen, and we do test for those. Many of the newborn screen tests test for proteins, test for metabolites. They might test for other substances that the proteins were supposed to break down, but we'll get into all of that in a different module. And I'm going to talk about cell-free DNA. Cell-free DNA is where we have some fragments of DNA found, usually in the blood. Your book says urine. I have never seen urine used, and I have had several patients who have had cell-free DNA done from the serum. Fetal DNA fragments are found in maternal circulation as the baby develops or fetus develops. Sometimes cells are shed. Those cells break down. They make it out into maternal circulation, and the strands of DNA that are found can be analyzed. And we can look for things like trisomy 13, trisomy 18, trisomy 21, some of the more rare trisomies. If it's a mosaic case, that's not incompatible with life, otherwise pregnancy would have ended. Um, and we can sometimes, now the technology is getting refined enough to look for things like microdeletions. Unfortunately, we don't know enough about the genome yet to understand all the consequences of those sort of smaller changes. Um, there are also applications in oncology for those of you who enjoy that subject. So when a piece of a tumor breaks off, and these cancer cells are kind of weird. We'll talk about that more. But you can sample some of those fragments of DNA that are found in the patient's blood, compare them to the normal genome, and see the changes to the DNA from the cancer. And you can kind of stage it. Where is it progressing? Is it responding to chemotherapy? You can even analyze that material to find out which particular therapeutic agents that cell is susceptible to, what's going to stop that cancerous cell. Cell-free DNA, the big advantage is that it is non-invasive and it is much less expensive than other more invasive, and there's really no risk to the client from cell-free DNA. Okay, moving right along, we're going to talk about pharmacogenomic testing that will be incorporated into your adult disorders lecture. Some clinically relevant genetic testing isn't done to diagnose disease or identify risk. It's done to identify effective treatments for disorders. And this is one of the most promising applications of genomic testing. We base treatments on the patient's genome that can alter response to medications. Usually we're looking at an enzyme. If you took pharm, you might remember CYP450, and there are many different enzymes in that family. It's like a super family of liver enzymes, and they metabolize medications and some food substances like grapefruit juice. So you can actually test a person's DNA, find out whether they are super metabolite or ultra rapid metabolizers, rapid metabolizers, whether they're slow metabolizers of medication. That's going to make a difference in how they respond. And there's going to be variation within that person. One enzyme might metabolize medications very rapidly. Another enzyme on that CYP family might be a little underactive. So we could really tailor that patient's medication and try and avoid adverse effects and side effects with pharmacogenomics. And then we have some non-clinical applications of genetic testing that you're probably very familiar with. If you've ever watched TV, ever, I'm sure you've seen something like the guy in the upper right corner collecting evidence. And you can identify a perpetrator. You can sometimes identify a victim who is unidentified. So we can use DNA for that. Paternity testing. You're probably very familiar with that. And really any other kind of kinship testing. It's kind of funny, when the direct consumer companies started coming out, there were all these news stories about people finding that their father wasn't their father, or that their brother was their half sibling, or they would get a notification that they had a half sibling somewhere all the way across the country or in some other part of the world. So it was kind of eye-opening that way. But it can also tell you about your ethnic heritage. And some people are just really curious about that. It's sort of a recreational use of genetic testing. And of course, we have genomic research. Those of you who are into social justice, you want to Google the life of Henrietta Lacks and just read the Wikipedia entry on it. And it's fascinating, but it's also upsetting. Henrietta Lacks was an African-American woman who was diagnosed in the 50s with cervical cancer. They saved some normal cells and some cancer cells. And even long after she died, without her knowledge or consent, they generated whole cell lines so that they could study cancer, they could study the human genome. And so we really owe a debt to Henrietta Lacks. But the story will probably make you a little angry, and it probably should. It was a highly unethical method of obtaining genetic material. All right, and that's what we have. If you access this presentation on the Google Slides, there's a little video for you. It's just a humorous thing from John Mulaney about how they used to solve crimes without DNA. And I'm going to cut this off here, and we're going to do another video on limitations and problems associated with genetic testing.